A miracle doctor.
My name is Lin Shu. 1 month ago, I awakened a label system. I can see things on patients, diagnostic labels, as long as I follow the label prompts and cure the patients. My medical skills will improve. Tell me, what seems to be the problem?
Doctor, my wife and I have been married for almost 6 months, but we haven't been able to conceive.
Physically, we're both fine. Then you two, are you using any contraception?
No, absolutely not, doctor. My wife and I both have PhDs. We're almost 30 years old. If we wait another 2 years, my wife will be at an advanced maternal age.
That's strange. What does this heavy addiction label above his head actually mean? Mr. Zhang, is it possible that in the bedroom?
I'm definitely fine in that department, honey, tell him.
What could Zhang Yang's addiction be that?
My husband is a bit intense in that area, at least 4 or 5 times every day. I even went to the hospital a few days ago to get hemorrhoid suppositories. The doctor even told us to be moderate.
Hemorrhoid suppositories. I think I might know the cause of the problem, Mr. Zhang. Let's exchange contact info.
After seeing you last time, within a month of going back, my wife got pregnant. That's amazing.
I feel like in my mind.
There are suddenly many memories of treating patients.
A true miracle doctor.
It's like I spent years studying in some parallel universe.
Time for ward rounds. Headache, vomiting, 37.2 degrees, no fever, most likely a migraine. Observe for now.
Mr. Wang, please take his temperature again.
I'll do it.
It's still 37.2 degrees Celsius. This temperature looks quite normal. It's not considered a fever, but why does the label indicate he has a fever unless this isn't his normal body temperature, ma'am? What is his usual body temperature?
Let me think. Last winter when he felt dizzy, I measured it once. It was around 35 degrees.
It seems I guessed right, Wang Jianxi. His baseline temperature is naturally low, 37.2. For a normal person, isn't considered a fever, but for him, he definitely has a fever. The label was right, no doubt about it. Dr. Zhao, regarding the patient in bed 3, I just asked the family. His baseline temperature is only around 35 degrees. 37.2 degrees for him might be equivalent to over 38 degrees in a normal person.
What are you trying to say?
I'm saying he might have a fever with the headache and vomiting. We need to rule out meningitis.
I just did an exam. The meningeal signs were negative.
Meningitis can be negative in the early stages.
Are you saying I missed a diagnosis? Are you saying I missed a diagnosis?
I'm not sure, but I think we should check again meningeal signs or perform a lumbar puncture.
How long have you even been here? A lumbar puncture isn't as simple as taking someone's temperature. First of all, it's not cheap. It's considered a major procedure. Secondly, who's responsible if we don't find anything? Can you take that responsibility?
Lin Shu, you're just a medical trainee. Why are you meddling?
Wong next month. Is your 50th birthday. Why not ask your daughter to come home for dinner?
What do you know about these things? She's busy with work right now. Don't just bother her.
But it's almost been half a year since I last saw her.
Don't you usually stay in touch over the phone?
A phone call is nothing compared to seeing her in person.
Medically speaking, once meningitis is confirmed, the time from onset to death is very short. Especially bacterial meningitis. It can take as little as 3 days for a life to be lost.
Do you want an orange?
No, thanks. Hello, I'm calling from the ER. We have a patient in the observation area, a 51-year-old male, 3-day headache, vomited once. Temperature is 37.2, but his baseline temperature is only around 35 degrees. I suspect it might be meningitis. Meningeal signs, I'm not certain yet. Could you please come for a consultation?
Mr. Wang, let me check you. I called them myself.
We need to do a lumbar puncture immediately.
How is he, Dr. Bacterial Meningitis?
Luckily, we caught it early. There's still time for treatment, otherwise the consequences would be severe.
Thank you, Doctor. Doctor, thank you. You're a good doctor, such a good doctor.
After resolving the patient's labels,
I feel like...
my medical skills have improved.
This ability is truly amazing.
Dr. Zhao.
Come to my office later.
Luckily, nothing went wrong this time, medical doctor team. If anything had happened, your residency would have ended right there.
Thanks for the reminder, Jen.
You bypassed me to call a neurology consult. The result proved you right. The patient was saved. Based on the outcome, you did a good job. It's worth commending. But procedurally speaking, you're a trainee. You don't have the authority without the attending's knowledge to call for a consult from another department. If this were reported, it would go on your residency record. I won't report it this time. If anyone asks, I'll say I authorized the call. Thank you, Dr. Zhao. I'm not finished. You're not allowed to see patients for the next 3 days. You're not allowed to touch them either. Take the department's residency management regulations and the consultation protocols and review them thoroughly. In a hospital, protocol is very important. Now go.
Have some water.
Thanks, Cam.
Dr. Zhao is just trying to protect you. Saving lives is the right thing to do, but every hospital regulation is designed to ensure. While you're helping patients, you can also protect yourselves.
Thanks for the advice, Jen.
Right, carry on then. I'll get back to work. A car grazed me. Just a scrape. Wanted to get it checked.
I was on my e-bike, a sedan grazed me while making a right turn. It's not serious, it wasn't going fast, I just fell over.
Where are you hurt?
My left elbow is scraped, and here on my left ribs it took a hit. It doesn't hurt.
Did you call the police?
No, I'm in a rush. Can we make this quick? I still have deliveries to finish.
Fill out the form first.
This description is terrifying. It's still bleeding. What exactly is still bleeding? Get some rest when you get home. Don't lift anything heavy for a few days.
Just take one if it hurts.
3 times a day at most. Okay, thanks for your help, Doctor. I'm heading out. Mum, I'm fine. It's just a scrape. You don't need to come to the hospital for Dad's medicine. Once I get paid next month, I'll transfer it to you.
His gait is steady. No limping. He's not clutching his stomach.
I understand. I'll pick up Duo tonight. Tell her Daddy is fine. His complexion looks normal. No blood from his nose or mouth. His breathing is steady too. Everything looks fine on the outside. But the floating label still says, still bleeding. His external wounds are already dressed. That means the bleeding is internal. Which internal organ would be bleeding? His left ribs took an impact. The organ in the upper left abdomen is the spleen. Could it be a delayed splenic rupture? This condition seems stable on the outside, with normal vital signs, but once it ruptures, it leads to immediate shock. If it's a splenic hemorrhage, there should be a CARES sign, one way to find out. Excuse me. It's definitely a positive CARES sign.
Dr. Zhao, what's wrong? Is it an emergency? Dr. Zhao.
What's going on?
A patient just came in. A 23-year-old delivery man riding an e-bike. Impact to his left ribs. Chen Yuan handled it. He cleaned and bandaged the wound, prescribed some painkillers, and was about to discharge him.
And then?
But I suspect he has subcapsular splenic bleeding. He was hit under his left ribs, right where the spleen is. I just did a quick check. His left shoulder has no trauma, but he's showing signs of pain there.
Where is he?
Getting medicine at the pharmacy.
Didn't I tell you to read the 3-day residency manual?
I overheard his phone call. His father is sick, and his daughter is still in school. Where's that delivery man, the 23-year-old one, the one with the bandage on his left hand?
Oh, him! He just left after picking up his medicine.
Hey, you can't leave yet?
I've already paid.
Your internal organs might still be bleeding. You're in a dangerous condition.
The other doctor already checked me. He said I was fine.
I know, but we need to do one more check.
I know my own body.
Better than anyone. I don't feel any pain. Your hospital just wants to make more money.
I'm an attending physician in the ER. My name is Dr. Zhao. Your left ribs took a hit.
I was just grazed a bit. It's nothing serious.
I have deliveries to make.
Or they'll be overdue.
Come back with me for an exam. Just 5 minutes. It won't take long. If everything is fine, I'll personally see you out.
Fine, I'll go with you. But if the check shows nothing, I'm going to report both of you.
This isn't good. That looks like my patient. My patient is coming back with Dr. Zhao.
I'm screwed.
Doctor, I should be fine, right?
You're actually in trouble. Your spleen is damaged. It's bleeding. Though not much right now, but it's getting worse.
Internal bleeding.
After the impact to your left ribs, your spleen was injured. The blood is trapped inside. Once it can't hold it anymore, it will start gushing out.
You'll need surgery.
Most likely, yeah.
How much will it cost?
Do you have medical insurance?
Yes, it's the rural kind.
From out of town.
Then a portion can be covered. The specific costs will be calculated after you're admitted.
I can't afford to stay in the hospital.
If you don't treat it now, the bleeding will only get worse. Once the splenic capsule ruptures, you'll go into hemorrhagic shock within minutes. By then, it won't be a matter of money anymore.
My daughter is waiting for me to pick her up tonight.
I'll call your family to come over. Give me their number.
Call my mom. Thank you, doctor.
Lynn, you can start seeing patients tomorrow.
Okay.
Come to me first next time, regardless of whether you have evidence. Just come to me first.
I feel like my medical skills have improved again.
When he came earlier, I did a basic checkup. He said he was fine too. So I didn't think much of it.
You're back early today.
Did I wake you?
I'm used to it. Since you're back so early today, I'm actually not used to it.
A trainee joined our department. He's pretty good.
To get a compliment from you, he must really have some talent.
What do you mean, get a compliment from me?
I'm saying you have good taste, honey.
You're here early today.
I just got here a moment ago, too. The dorm is close to the hospital. It's just a few steps away.
Ha 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 ha. All right. When you're at the clinic later, let me know if anything comes up. Dr. Zhao, I'm heading to the clinic then. Go ahead.
Doctor, my chest feels tight.
How long has it been?
About 2 days. It's not all the time, only when I'm active. Sometimes when I walk fast or when I climb stairs, it gets better after I sit and rest.
Does it hurt?
No, just tight. It feels like something is pressing on my chest.
Has this happened before?
No, this is the first time.
Any sweating or nausea?
No.
Do you smoke? Do you have high blood pressure?
I do. For over 30 years, a pack a day. I have high blood pressure. I'm still taking medication for it, but not every day. Sometimes I forget.
Any family history of heart disease?
No diabetes, but my father passed away from a heart attack. He was 68 at the time.
30 years of smoking a regular medication for high blood pressure. We need a further assessment. Let's do an ECG first.
All right, thank you. Doctor, please hurry. I have a chess game scheduled this afternoon.
Heart rate 76 BPM, regular rhythm, normal axis, normal PR interval. There is a slight ST segment depression about 25 millimeters. This number is tricky. It's a gray area. The textbook diagnostic criteria is greater than or equal to 1 millimeter, 0.5 millimeters. Could be within the normal range of variation, or it might not be.
Doctor, I'm okay, right?
If it were a healthy young person, this value would be fine. But he is 62 years old, smoked for 30 years, high blood pressure, father had a heart attack, chest tightness for 2 days, worsens after physical activity. The risk factors are really stacking up, looking at the young doctor's expression.
Something might really be wrong with me.
That's the third time I've seen a label changing. What exactly is changing? This label is very vague. It doesn't give me the answer directly. Instead, it points me in a direction, letting me judge for myself. Fever pointed to an overlooked body temperature, still bleeding, pointed to hidden internal bleeding. Changing. Could it be an ECG is like a photograph? It only represents a moment of cardiac electrical activity. It can only tell you the heart state at this moment, what it's like. It can't tell you the heart's future state. I need a second ECG, but not right now. It needs to be 30 minutes apart. To an hour later, Mr. Wu needs a blood test, then we'll observe you for an hour, and an hour we'll do another ECG.
It'll take that long. Why do we need two?
To compare them and see if there are any changes.
Doctor, I'll be okay, right? I actually feel like it's not that bad. My wife insisted I come here. I thought if I just lay down at home, I'd be fine.
Since you're already here, let's get it checked out so you can have peace of mind, right?
I have a chess game this afternoon. I think I'm fine. Oh, fine. Since I'm here, let's just do it.
The situation isn't good compared to the ECG. From an hour ago, the ST segment depression has worsened. Your current condition is called unstable angina. It needs immediate treatment. If left untreated, it could develop into a heart attack.
Heart attack? How could it be a heart attack? Doctor.
Yes.
Please don't tell my wife. I told her I was just getting some cold medicine. She has a weak heart. I'm afraid she'll worry more than me if she finds out.
You'll need to be hospitalized later. Your family needs to know.
I know I'll tell her myself. Please don't call her. If she hears it from a doctor, she'll be worried sick. Hey dear, it's nothing. Just a minor illness. The doctor said I need to stay in the hospital for a couple of days. The hospital air isn't good. You don't need to come. I'm a grown man. Don't you trust me?
Please lie down on the bed.
Okay, I'm going for the test now. I'll call you back later. Dr. Lynn, sorry to trouble you.
The first ECG, the ST segment, was only slightly depressed. The myocardial enzymes were also normal. What made you think of doing another one?
He has too many risk factors. 30 years of smoking. Family history of hypertension. Chest tightness for 2 days. Although the ST segment isn't typical, given the background, we can't overlook it. When a single chart is inconclusive, looking at dynamic changes is more reliable.
That's very meticulous. I've learned something. By the way, at the end of the shift today, there's a handover report. Remember to be on time.
Got it, I know.
We're adding a case discussion today. Lin Shu, please present the patient you're treating, Wu Guoliang.
Male patient. 62 years old, chief complaint. Chest tightness for 2 days. Worsens after physical activity, relieved by rest. History of hypertension. Irregular medication use. 30-year smoking history. 1 pack a day. Patient's father was 68, died of a myocardial infarction. Physical exam, BP 148/92, cardiopulmonary auscultation. No obvious abnormalities found. The first ECG ST segment depression in leads. V4 to V6, approximately 0.5 millimeter, does not meet diagnostic criteria. Myocardial enzymes and troponin all within normal range.
The data looks normal. What made you think of rechecking and doing a second ECG?
Because there were 3 words above his head.
This decision you made was a bit aggressive procedurally, but the results prove your judgment was correct. Well done. Lin Shu's approach today is something you all should learn from.
Director Shen, you're giving us too much credit. How are we supposed to learn that, Sai? I heard that for resident physicians this year, the pass rate for the graduation exam is even lower than last year. At the same time, there's someone like Lin Shu, a naturally gifted powerhouse. What am I going to do?
Dr. Lin off work already?
Haven't eaten, I'm starving.
No, we recently admitted a tricky patient.
What's the situation?
A little girl. Only 10 years old. Recurring low-grade fever for a month. She's been to 3 different hospitals, and none could find the cause. Now she's been transferred to our department. Several people in our department looked at her, and we're all clueless. Even Dr. Chen hasn't figured out a direction yet. Everything that could be checked has been checked.
Recurring low-grade fever for a month. For complicated cases like this, will there be a label? I've seen quite a few patients lately, and I've noticed ordinary patients don't show labels. Only when the condition is complex or unique will they appear. Do you have Practical Pediatrics, that book?
Yes, but it's in the office if you want it. Come pick it up tomorrow. Okay.
Hello, is Joe Han here?
Dr. Joe is still on rounds. Just wait here for a moment.
Okay, thanks. What do you mean by more than one? More than one symptom, more than one disease, more than one organ, or more than one cause?
I'm here to borrow a book. Let's go to my office to get it.
Ward 3, that little girl, the patient you took over.
You're interested in her condition?
Just curious.
See for yourself.
The data looks normal.
Right, that's why it's so tricky. We can't find the cause.
Where does it hurt?
He said his knee hurt a bit a couple of days ago. It's not obvious, I've already told Dr. Liu. The physical exam showed no joint swelling. The x-ray was fine too. For now, we're considering growing pains.
Which knee?
The left knee?
We still need to rely on the lab results. Guessing alone isn't accurate.
Aren't you in the ER? Why are you so concerned about this?
3 hospitals couldn't figure it out. That's quite rare.
You're the type who can't walk away from a challenge.
Found it. The data here isn't right.
What did you find?
This trend isn't right. Look here. His hemoglobin 22.06, platelets 285, 310, 338. This suggests there might be a persistent low-level inflammatory response.
Such a subtle detail and you noticed it. I'll go tell Dr. Liu.
Wait. How are you going to say it?
I'll say you discovered it.
Don't say it was me. Say you found it yourself.
Why? You clearly deserve the credit.
Because I'm a resident in the ER, and this is a pediatric patient. You're the primary doctor. It's more appropriate for you to say it. Our goal is to save the patient.
I thank you on behalf of the patient.
What's wrong?
I reported to Dr. Liu and showed him the platelet and hemoglobin changes. Over the past few weeks, I mapped out the trend for him.
What was his conclusion?
He said the trend does exist, but every test result is within the normal range. He thinks this level of variation in indicators isn't rare for hospitalized patients. Changes in diet, less activity, or even repeated blood draws can subtly affect blood counts.
What do you think?
I think your hunch is right. Routine tests don't show anything, but this series of abnormal values is something we should pay attention to. At least we shouldn't ignore it.
Have some water first. How does Dr. Liu plan to handle it?
He said to keep observing and wait for next week's follow-up to do another blood count. If the trend continues to worsen, we'll reconsider the diagnosis.
In that case, when you do the follow-up next week for the blood count, add one more indicator.
What indicator?
Serum ferritin.
Why's that?
Simply put, checking ferritin can distinguish whether it's anemia causing the abnormal values or if it's inflammation causing them, because if it's chronic inflammation leading to anemia of inflammation, inflammation will lock iron inside multinucleated cells, ferritin levels will rise. If it's simple anemia, ferritin will drop, so once ferritin is checked, it will confirm if it's an inflammatory issue.
Brilliant.
That patient just now, suppurative tonsillitis. Give him a ceftriaxone skin test. If there's no reaction, start a 2G IV drip. Add some ibuprofen to reduce the fever. Once his temperature drops to 38 degrees or below, he can leave.
Help.
Open your mouth. Let me see inside. The mucosa behind the tonsils, severe cystic bulging. If it gets any worse, he won't be able to breathe.
Get out!
Your patient is deteriorating.
Just a moment, ma'am. Hurry, get him on the monitor immediately. Check his oxygen saturation. 10 melos IV push of keltistamo to reduce the edema. Request an ENT consultation and the anesthesiology department. I've already made the calls. They're on their way.
Dr. Lin, here are the tools you wanted.
It's too late if we wait any longer before the doctors even arrive.
He'll likely be brain dead. Perform a cricothyrotomy immediately. Help me out. Help me stop the bleeding in a moment.
Man, are you crazy?
Nurse, help with the light.
Hold his head still. Trust me, I can do this.
I've shattered quite a few labels lately.
Compared to before, my medical skills have improved a lot.
A cricothyrotomy
is a medium difficulty procedure. I should be able to do it. So accurate, so fast. Incredible technique.
In him.
I can actually see my mentor's shadow. Is he really our peer?
Mission accomplished. The surgery was a success.
You performed the surgery?
The situation was critical just now. There was no time.
I took a look. The incision is very precise. The wound isn't large either. If I were to do it, I probably couldn't have done any better. It's quite impressive.
As expected.
Talented people stand out wherever they go.
This kind of surgery is very draining. I'll take him to rest.
This is your patient. You should stay here for now and look after the patient. Dr. Lin, I'll get you some water. Looking at you, the results must be out.
They are. I did as you said for Sue Jinian and ordered a serum ferritin test. Guess what the serum ferritin level is?
Data is rigorous, I won't guess.
You are so literal fine. Her ferritin level is 235.
I remember the normal range is 20 to 200.
Exactly. Moreover, hemoglobin is 102 compared to last week's 106. It dropped 4 points. Platelets are 358, up 12 points from last week's 346.
What did Dr. Liu say?
Dr. Liu reported it to the medical department. He asked rheumatology and immunology and hematology to conduct a joint consultation.
Are the results out?
Not yet, but we should know by tomorrow. I'll tell you tomorrow.
Okay.
Today the results came out.
Judging by your expression, it might be bad news.
Rheumatology and hematology ran some tests on her. The conclusion is, based on current evidence, it's not enough to diagnose any specific rheumatologic or immunologic disease. The patient is ANA negative. Complement levels are normal. Joint symptoms are atypical. Recommend regular checkups of inflammatory markers. Watch for any new clinical symptoms. So the bottom line is, she's not sick.
Send me the medical records.
You have a theory.
A little bit, but I'm not sure yet. First there's chronic inflammation, which then triggers fever and joint pain. Then the anemia worsens, followed by a reactive increase in platelets, finally a loss of appetite. And a sudden drop in weight. It's like a tree before the leaves turn yellow and fall. The roots underground have long since rotted. I saw him in the ward earlier. Only the fingers on his left hand showed signs of disease, developing into clubbed fingers. If it were a systemic disease, the changes should be symmetrical. Since it's only on the left hand, that suggests the lesion is localized. What kind of thing only affects the left extremities without affecting the right one's blood supply? The blood supply to the left and right hands follows different pathways. After the blood is pumped from the heart, it takes 3 routes. The first goes right from the brachiocephalic trunk, supplying the right upper limb and the right brain. The second goes up the left common carotid artery, supplying the left brain. The third vessel goes left from the left subclavian artery, supplying the left upper limb. So,
A 10-year-old girl fainted and fell forehead trauma. Loss of consciousness. Recovered spontaneously after about 10 seconds, currently drowsy.
Doctor, I've seen you in the ward.
Be a good girl. Everything will be fine. You'll feel better after a nap. I'm going to help you. Let's check what's making you sick, okay?
Thank you, Doctor.
hand me the blood pressure monitor.
Blood pressure in both arms, the difference is actually this large.
Left arm BP is 6835. Right arm BP is 9560. The pulse is very weak. It's like through a wall, a distant knocking sound. The right pulse is very clear and very steady. The pulses in both arms are completely different. The answer is getting closer. Zhu-Han, give me the stethoscope. I found the cause. Make a call, ask Dr. Zhao to come here immediately.
Okay.
He's been hospitalized for so long your pediatrics department can't even find the cause. This is ridiculous. Without knowing the cause, how can we save him?
I found it. I found the condition. Left arm BP is 6835, right arm BP is 9560. The systolic difference is about 37 mmHg low-grade fever for 3 months. Elevated CRP and ferritin rapid EDSA. Hemoglobin continues to drop, platelets continue to rise, ANA is negative. Normal complement and bone marrow biopsy. Unilateral clubbing in the left hand, accompanied by localized migratory pain in the left knee. Significant weight loss in summary. Takayasu arteritis.
Hello, radiology. This is Zhao Shuifeng from ER. I need to give a 10-year-old patient an aortic and branch CTA immediately. Take the patient to radiology. Takayasu arteritis is actually very rare. Pediatric Takayasu arteritis. Have you seen it before?
Not in person, but I've read about it in books.
3 hospitals couldn't.
Diagnose this complex case, but you found it directly. Are you interested?
And staying to work in the ER?
I'll follow the hospital's arrangement. I wonder what level my medical skills have reached now. Every time my skills improve, I feel like I've actually been in the hospital, treating patients for years. Does this count as working for 1 month? With 10 years of experience as a senior doctor?
Last night, the ER admitted a pediatric inpatient after repeated physical exams, a low-grade fever for 3 months, unmanaged after visiting 3 hospitals. Fainted and fell down and was sent to our ER, the physical exam revealed. Blood pressure in both arms is asymmetrical. On the left side, the radial artery pulse is weak. In the left infraclavicular area, a vascular murmur can be heard. The CTA scan confirmed it's Takayasu arteritis. The patient has been moved to rheumatology and started steroid treatment. The initial diagnosis was made by Lin Shu from our department.
That's pretty impressive. I heard it was a tough case. This girl visited several hospitals, but none of them figured it out. Once she came here, it was diagnosed immediately.
We're all from the same batch. How is he so talented?
All right, that's it for the morning meeting. Get back to work, everyone.
Doctor, my dad's heart is racing like crazy. It's been going on for a week, but he refused to see a doctor. He almost collapsed while working today. I had to drag him here.
It's no big deal. My heart's just beating a bit fast. I'm fine.
What are the specific symptoms?
It's fast one moment and slow the next.
There's no pattern to it. Have you had this before?
No, this is the first time.
Recently, have you noticed any sudden weight loss?
Not really.
What do you mean you were fine last month?
But this month, you've tightened your belt by an extra notch.
Your pants keep slipping down.
Sir, has your appetite decreased?
I'm eating just as much.
Actually.
I'm eating even more than before?
But I get so hungry at night it makes me jittery.
Eating more but losing weight unexpectedly. Go get an ECG done.
For the ECG.
And a thyroid function panel.
Is all this really necessary? I feel perfectly fine.
Dad, just listen to the doctor. Since we're here, let's get a full checkup. Dr. Lin, my dad's thyroid test results are in.
Accelerating heart rate is increasing. Basal metabolism is burning. Appetite has increased, but weight is dropping. Looks like I was right. It is atrial fibrillation caused by hyperthyroidism.
Dr. Lin, is my dad's condition serious?
Your father has a thyroid-induced complication of atrial fibrillation. It can be fully controlled with medication.
Thank you, Dr. Lin.
Don't worry, this condition can be managed. You go ahead.
Nyanian, look who's here.
Big brother.
How's the recovery going?
Much better. I had a bowl of porridge this morning and 2 boiled eggs.
What are you reading?
Uncle Joe gave this to me. It has big goldfish on it.
The doctor said the indicators are dropping. CRP dropped from 12 to 7. Yesterday's temperature was 36.8, no fever for 2 days. Thank you, Dr. Lin.
Just doing my job.
So you're Lin Shu?
Yes, that's him. He's the one. 4 hospitals couldn't figure it out. The patient was at our hospital for nearly a month. No one had a clue until he alone diagnosed Takayasu arteritis Lin Shu.
He's quite impressive.
That's just how he is. No matter what you say to him, he always stays so calm, the stoic type.
Takayasu arteritis. I've only seen it in books. The textbook says there's only 1 page about it. Cases are extremely rare.
So, a disease with only 1 page of documentation. He recognized it at a glance. The gap between people. Why is it so huge? See that? You're famous now, by the way. You're pretty impressive. Such a rare disease.
How did you diagnose it?
Xiaoshu. Mom gave you this name because she hoped you would grow up strong like a big tree. When Mom is gone one day, you must take good care of yourself.
I'm sorry, lupus aortitis. It was detected too late. Mom. I'm full. You guys go ahead and eat.
Dr. Lin, I heard about Sujinian's case aortitis. You have keen observation skills.
Thank you for the compliment, Dr. Liu.
You asked Johan to check the ferritin levels and told him to watch the trend. You were the one who tipped her off.
We discussed it.
Discussed. Thanks for your discussion.
Tomorrow at 3 o'clock p.m., come to my office. Bring that case's inspection records. Shen Yue said she wants to turn it into a teaching case to use for training residents later.
To use for training other residents, but I'm a resident too. This is a bit too high profile.
Did you notice the asymmetry of the clubbed fingers first, or did you notice the low blood pressure first?
The clubbed fingers first.
When was that?
Once when I went to the ward, I saw her holding a cup to drink. The curvature of her left index and middle fingers was greater than her right hand.
And then? So before he arrived at the ER, you already had a direction.
A vague direction, but I wasn't sure I had to wait for the test results. Let the physical data speak for itself.
That's good. I'll organize this case into a teaching version for next month's residency to use in the training class. Your name will appear as a case contributor.
Thank you, Director Shen.
I remember when he first arrived. There was one time an appendicitis patient was there for 10 minutes and he couldn't figure it out.
This shows he's progressing very quickly. He can apply what he's learned. By the way I remember, it's almost time for the residency rotation.
Right, the resident rotation date is October 8th.
Which department is he going to?
Let me see. General surgery.
I'm in respiratory medicine. I heard general surgery involves going under the knife. Can you handle it?
I should be fine.
General surgery, it's different from the ER. The pace is different. The mindset is different too. You have a solid foundation in internal medicine, but in surgery you must learn to work with your hands.
Thank you, sir.
I heard you're moving to general surgery. That's good. You'll learn different things in surgery. While you were here, you did well. You're going to be a great doctor. Dr. Lin, come back and visit the ER when you have time.
I will.
I heard Dr. Zhao went to see the vice dean. He said you're a promising talent for clinical work in the ER. He hopes to have you assigned to the ER eventually. Key points for positioning in Zone C.
This spot is hard to resect.
And you are.
Hello, I'm the new resident Lin Shu.
So you're Lin Shu Wei Ming Chuan, your supervisor.
Dr. Wei, I look forward to learning from you.
Come here, let me show you around the department. This is the nurse station. Head nurse Lu is in charge. If there's an issue with your medical orders, she'll call you. Don't worry, she's actually quite nice. She just talks fast. You'll start following dressing changes tomorrow. Just watch for today. You'll do it yourself the day after tomorrow. The location of the iodine gauze and forceps, make sure to remember them today. The OR is on the 5th floor. Wear scrubs when you're in the OR. The locker room is around the corner. Shoe covers are in the cabinet by the door. Don't put them on backwards. An intern put them on backwards last week and got scolded by the head nurse. That's Guran. A resident, you can ask her if you're unsure about anything. She's quite busy. Try to ask when she's not occupied. You'll start with 3 beds. Beds 12, 13, and 14. It's not too many. Just get familiar with the environment first. Bed 12 is a cholecystectomy. 2nd day post-op. Recovering normally. Bed 13 is 3 days post-appendectomy. They can get out of bed today. Bed 14 is a hernia case. A laparoscopic hernia repair is scheduled for tomorrow. You'll be the 3rd assistant. Bed 12's drainage tube needs to be removed later. Go check it first. The volume and color of the drainage. If it's less than 50 be thorough and pale yellow, it can be removed. Call me when you're ready to pull it. Oh, by the way, about that Takayasu arteritis case, I heard about it. That was a brilliant diagnosis, but surgery is mainly about your manual skills. I haven't seen what your hands can do yet. We'll see when you pull the tube this afternoon.
The new guy.
Lin Shu, he reported for duty today.
Yes.
Bed 12's drainage tube can be pulled today. I checked it this morning. The volume was under 40. The color looks normal. Have Dr. Wei supervise you while you pull it. Don't do it on your own.
Okay.
You do it.
Go ahead. Hey, it doesn't seem as painful as last time, Dr. Lin. You have great technique.
Have you practiced this before?
They taught us in school.
Your hands are steady, not like a rookie's. That's good, though. I hope during tomorrow's surgery you'll perform just as well. Look here. This layer of the transversalis fascia is very important. This is where the hernia protrudes through the weak point. See that? Guren, you dissect this section. Lin Shu, you handle the suturing. The surgery was a success.
Thank you, doctor.
That's some good suturing. If I hadn't seen you do it yourself, I would have thought an attending physician did it himself.
You flatter me, Brother Wang.
I heard your department recently got a new resident. How is that kid's actual hands-on ability? Ha ha ha, you, that picky nature of yours is exactly how I was when I was young.
I have work to do, hanging up.
Sir, I'm here to do a post-op check on you.
Why another checkup?
Just one more check.
All right, come on. Oh, it hurts.
Dr. Wei, the patient who had surgery yesterday. The patient in bed 14 has signs of slight peritoneal irritation. In the lower right abdomen, tenderness is positive. Rebound, tenderness is suspiciously positive, and it's nowhere near the incision.
What's the situation? Didn't you say the surgery went very smoothly?
The surgery went very well, but depending on individual differences, there might be some post-op symptoms. That's why we asked you to stay for a few days of observation.
All right, then.
A small amount of oozing blood. The amount isn't large, so let's observe first fluid resuscitation. Recheck the blood routine in 4 hours. If the hemoglobin is still dropping, we'll talk then. The incision looks fine. How did you think to press that spot in the lower right abdomen?
Habit. I'm used to checking every area during a physical exam.
Not just near the incision. Do they teach this in the ER?
Just a personal habit.
No wonder you caught that Takayasu's arteritis. Good habit. Keep it up.
Oh, the surgical hotshot is here. How many people did you cut today?
I didn't cut anyone, I just watched others.
That's fine too. Did you see any blood? How do you feel? Tired?
Saw some blood, it was okay.
I heard yesterday was your first time doing sutures on the table and your stitches were even neater than the senior doctor's. Did he say that?
I heard it from a visiting student in the group. They all say you're good at internal medicine and surgery as well. After residency, you'll most likely be able to stay. Hey, did you see Guran from your department?
They're in the same department. Of course he saw her.
I saw her. I heard Guran has a nickname called 2mm because she requires suture precision to be within exactly 2mm. None of the surgical residents aren't afraid of her.
In surgical suturing, a 2mm error is actually quite wide.
I have nothing in common to talk about with a big shot like you, but I did think of something. Tell me if she gets a boyfriend in the future.
When they're kissing, would she complain that he's off by 2mm?
Is your tongue laced with poison? Besides, her skills are indeed good. It's a good thing to have someone point out your flaws to your face. It's only scary when no one does. Those were the original words of my mentor back then. Now I'm passing them on to you.
Oh, Ms. Jiang, why do you sound like an old Professor Lin Shu? Who do you think has better suturing skills, you or Guran? Hey, look at him. When you talk to him, he's always like this, a total man of few words.
That's called the modesty of a master. You think everyone is like you making a fuss every single day.
If Lin exists, why must Chen exist too?
Dr. Lin, we're being discharged. Thank you so much.
It's my duty.
We bought some fruit for you. Please don't be so polite.
I can't accept this.
It's just a small token of our appreciation. I know the hospital has rules now. No cash gifts. It's just some fruit. Wishing you continued success in your career. A prosperous future.
Big brother, you haven't visited in a long time.
Where's your mom?
My mom went to look for a job. She said she wants to find one near the hospital. That way she can come and be with me often after work.
So young and yet so mature.
Big brother, which department are you in now?
General surgery is...
I know that's where they perform surgeries, big brother. Have you ever performed surgery?
a few times.
Were you scared?
Not at all.
I used to be so afraid of shots, but here I get shots every day. Now I'm not afraid at all.
Nyanyan is the bravest.
The whales in this book aren't as cute as cats, but its story is longer. I love the ocean. My mom promised me that when I get better, she'll take me to see the ocean.
That's great. After you see the ocean, come back and tell me what it's like there.
Boss, are you still hiring?
Yes, for a clothing sales associate, base salary is $3,200 plus commission.
Do you have experience? Yes, I do. I worked for 4 years before.
Then why did you quit your last job?
To take care of my sick child. Now that my child's condition is stable, I won't let it interfere with work.
All right, let's do a one-day trial today. If it works out, you can start tomorrow.
Thank you, boss. This is your newly assigned patient.
Acute cholecystitis, thickened gallbladder wall, small amount of pericholecystic fluid, multiple stones in the gallbladder. From the look of it, it's not too serious. Acute cholecystitis isn't uncommon in general surgery. Dr. Wei has already scheduled surgery for the day after tomorrow. Laparoscopy routine cholecystectomy. Go and take a look first.
Doctor, what's wrong with me?
I am Lin Shu, the doctor in charge. I'm going to perform an admission physical exam.
Okay. Thank you.
Recently, has there been any change in your weight?
I've lost some weight.
Roughly how much?
6 kilograms.
Soybean size, it's hard and mobile. Does it hurt?
No pain.
Really, it doesn't hurt.
It doesn't hurt. What's the matter?
It's nothing, just a standard part of the exam.
Come in.
Dr. Wei, regarding the patient in bed 22, the admission physical exam, I have a few findings I'd like to discuss with you.
Go ahead.
The Murphy's sign is atypical.
When pressing on the gallbladder point, I had the patient take a deep breath. He inhaled fully without any interruption. The pain is persistent, but not sharp.
For cholecystitis, the Murphy's sign isn't always typical. Chronic cases can sometimes present as a dull ache.
The patient's weight dropped by 6 kilograms in 6 months, from 72 kilograms down to 66 kilograms. Both he
and his family confirmed it.
Anything else?
In the left supraclavicular fossa, a lymph node can be felt. About 1 centimeter, it's hard, fixed, and painless.
Dr. Wei.
Let me check for you again. The CT report.
Let me take another look. Order an enhanced CT scan for the abdomen and pelvis. Schedule it for tomorrow morning and put the surgery on hold for now. What do you think it could be?
It's hard to say. Hopefully it's a misdiagnosis. Let's wait for the report.
You're right. Wait for the report. Gallbladder cancer, and at least T3. It's invaded the serosa lymph node metastasis near the cystic duct and the abdominal aorta.
It's confirmed.
Confirmed we'll need an open surgery to perform a radical cholecystectomy, extended resection plus lymph node dissection.
Get an oncology consultation. Who found this?
Lin Shu, the new resident on rotation.
The name sounds familiar. Is it the Takayasu arteritis?
Takayasu arteritis. What kind of nickname is that? I have a name, you know. My name is Lin Shu, not Takayasu.
Yeah, it's him.
He found it during the physical exam. He's the one who caught it. He did it all by himself, based on his comprehensive judgment.
Let him continue managing this bed. The follow-up CT results are out. We found that the gallbladder issue is more complex than we previously thought. It's not just simple cholecystitis.
What is it then?
We're currently considering a space-occupying lesion in the gallbladder. We need further tests to confirm. We've already scheduled a PET CT scan and an oncology consultation.
What's that? Doctor, what you're saying is a bit complicated. I don't understand.
Is it serious? We need further tests to make a diagnosis. We'll arrange it as soon as possible. If you have any questions, feel free to reach out anytime.
Ma'am, the PET CT scan is already scheduled. For the morning after tomorrow, once the results are out, oncology will come for a consultation. By then, we'll have a comprehensive treatment plan.
Dr. Well, the space-occupying lesion.
Does that mean it's cancer?
Dr. Lin, I'm being transferred upstairs.
The chemotherapy plan. The oncologist will discuss the details with you. If you feel unwell, press the call button anytime.
Thank you for finding it. If you hadn't caught it and we'd operated for cholecystitis first, only to find out then, that would have been much worse.
Dr. Lin. This is from the patient in bed 22.
They left it at the nurse station before leaving and asked me to give it to you.
Do you know what we see most in respiratory medicine? It's coughing. Nothing but coughing. This morning I saw 12 patients. 11 of them had a cough, and the other one was just picking up a report. It's gotten to the point where I've developed a reflex in the cafeteria. If someone coughs, I subconsciously want to reach for my stethoscope.
Since you're so professional, Dr. Chen, you should just stay in respiratory medicine.
No way, I actually prefer orthopedics. Orthopedics is great snap, and just like that you've set the patient's bone. Unlike respiratory medicine, where after 2 weeks the patient is still coughing. It's so frustrating. Lin Shu, how about you? You've been looking pretty busy lately. How's it going in surgery? I heard you caught another serious case. Yeah. What was it?
Gallbladder cancer.
How did gallbladder cancer end up in general surgery? Was she admitted as a case of cholecystitis?
Yeah.
How did you figure it out?
Physical exam.
Physical exam again. Are you a human CT scanner or something? Whatever the illness is, you just take one look, feel around a bit, and you've got the diagnosis.
It's not that exaggerated.
Not exaggerated, holy crap. If I could diagnose something like that through an exam, I'd be bragging about it for a year. Anyway, how's the patient doing?
Transferred to oncology for chemo.
Was it caught early?
Not really, it's already metastasized.
I saw you haven't had any water. Let me get you a glass.
Oh, thanks.
Is this surgery? This is the ER. We're sending up a female patient, 43 years old, acute abdominal pain. The CT shows abnormalities around the superior mesenteric artery, some fluid in the abdominal cavity. Requesting an emergency surgical consult. We need you guys. She's being wheeled up now.
Got it, we'll be right there. What happened?
Around 7 or 8 p.m. The stomach pain started. At first I thought it was just an upset stomach. He said he'd be fine if he just toughed it out, but it got more and more painful. He endured it at home for hours. Then he couldn't take it anymore.
I see, hold on. Dr. Wei ER just sent one up. A case of acute abdomen. A 43-year-old female abdominal pain for 6 hours. CT scan suggests mesenteric vessels surrounding abnormalities, small bowel wall thickening, hemoperitoneum. How are the vitals? Heart rate 102, BP 90, 60. It's low. Start IV fluids, give vasopressors. Check CBC biochemistry, coagulation profile, liver function, and creatinine. Get a contrast-enhanced abdominal CT. I'll be there in half an hour.
Overtime again.
There's an emergency transfer patient. I need to go check on them.
Drive safely.
Let me give you a physical exam. Try to relax as much as possible. This redness on your face, how long has it been there?
I don't really know. It might have been a while. I didn't pay much attention to it.
Does it get worse after being in the sun?
I think so. It's more noticeable in the summer. I thought it was an allergy, so I ignored it.
Family member, come over and help me out.
Doctor, what's wrong? Is it serious?
Help me roll up the patient's pant legs.
Okay.
acute abdominal pain, mesenteric vascular abnormality, symmetrical joint swelling, facial butterfly rash, aggravated by sun exposure, livedo-reticularis on lower limbs. Do you often get mouth ulcers?
Yes, they keep coming back. They heal and then reappear. Doctor, what's actually wrong with me?
Have you been losing much hair?
I've lost a lot this past year. When I wash my hair, it comes out in clumps. Doctor, you're making me nervous with these questions.
Let's wait for the test results.
How are the test results?
Dr. Wei, I found some other things.
Go ahead.
Patient reports joint pain for 6 months, recurring mouth ulcers for nearly a year, severe hair loss, facial rash worsened by sun exposure.
What do you suspect?
Systemic lupus erythematosus. The abdominal pain might be caused by lupus mesenteric vasculitis. It's not a blood clot, it's not an embolism, it's autoimmune.
Did you order the immunology panel?
Yes, Anna, and anti-destinate complement antiphospholipid antibodies.
When will the results be out?
It's an urgent request tomorrow morning at the earliest, Dr. Wei. If it really is systemic lupus erythematosus, we can't perform this surgery.
But if we're wrong, and we miss the window for treating an acute condition leading to intestinal necrosis, that would be medical malpractice. Wait here, I'll go call Director Han to give him a heads up. This kind of decision isn't something you or I can decide. I told Director Han he'll come to see the patient tomorrow morning. Let's do a CTA tonight. If your assessment is correct, we can't do surgery. It would be useless. Vasculitis needs steroids to be suppressed. It's not something a scalpel can solve, but if you're wrong, he'll lose his intestines.
Dr. Wei, I'll go fill out the patient's admission records.
Go ahead. I just personally performed an examination. CTA can rule out an embolism. The bowel is currently ischemic. Lactic acid is 2.8, thickening and edema of the small intestinal wall, segmental reduction in blood supply. If it continues to progress, it will lead to perforation. Instead of waiting for emergency surgery, it's better to be proactive with a laparoscopy to explore the internal condition of the bowel. At least we'll know what we're dealing with.
If it's bowel perforation plus peritonitis, passive emergency surgery has a high mortality rate. If diagnosed early, the survival rate is higher.
I'm leaning toward exploration.
Director Han, I don't think we should operate.
Why?
When I examined the patient, I found some things outside of the abdomen, the patient's hands, proximal interphalangeal joints, symmetrical swelling on the malar area of the face. A faint red rash is visible, distributed symmetrically in a butterfly shape, scattered on both lower limbs. Is livedo-reticularis. After sun exposure, the facial erythema worsens, increased hair loss, recurring oral ulcers. WBC is 2.8 in the blood routine. Platelets are 89. Urine protein is 2 plus, ANA is positive, titer is 1640.
ANA is positive. What does that prove? Infection can also cause a positive ANA, so can drugs.
But she has more than 6 criteria matching systemic lupus erythematosus clinical manifestations. I suspect she has systemic lupus erythematosus.
You're just suspecting. In medicine, we need solid test results. What about the anti-DSNA?
It's delayed. The lab said they need to retest expected by noon.
The patient's bowel is ischemic. With every passing second, her symptoms are worsening. You want the patient to wait until noon.
Dr. Lin, are you trying to say the patient might have systemic lupus erythematosus? If it is systemic lupus erythematosus, high doses of steroids are needed. Use steroids to suppress the inflammatory response. But there's a problem. If during steroid treatment, inside the patient, a bowel perforation occurs, we won't be able to find the location of the perforation because it'll be masked by steroids. That's very dangerous. It could easily lead to septic shock in the patient.
Fine. Then delay the surgery until 10 o'clock. But one thing, keep a close eye on the patient. Check lactic acid every hour, if it exceeds 4. Regardless of the results, she must be sent immediately to the operating room.
Dr. Wei, I want a request from rheumatology and emergency consultation.
Are you sure? This is just your own judgment. If you're wrong, it will have a very negative impact on you.
Dr. Wei, I trust my judgment.
Is this the lab? This is general surgery. We have an urgent complement test, C3 and C4. The patient's surname is Joe Joshua. Yes, can you prioritize the results? We need them urgently. Okay, thanks. They said they'll try.
Thank you, Dr. Wei.
You're welcome. If you're right, you'll save her life. If you're wrong regarding Director Han, I'll take the responsibility for you.
Doctor, my wife is in pain again. It's even worse than before. What is wrong with you people? Why has it been so long and nobody is helping her? We came from the ER. The ER doctor said she needs surgery, but you haven't done it. Isn't this the best hospital in the province? Are you guys competent or not?
We are performing further tests. The results will be out soon. Once they are out, we will have a clear plan. We won't keep her waiting.
Fine, you're the doctors, you call the shots.
Is this OBGYN about the complement test you requested? C3 is out, C4 is still processing.
What is the C3 level?
Charge 2-1.
That's so low, it's not even a quarter of the normal value. Back then, my mother's
medical records
only showed 0.42.
This won't work.
Director Han, the complement level is severely low. Combined with the ANA, the titer and multi-system involvement, I don't diagnose systemic lupus erythematosus.
I'm a surgeon in general surgery. A surgeon. The final diagnosis of this case must be made by the rheumatology department. Where are the people from rheumatology?
They said about half an hour. They should be here soon.
It's 9:40 now. There are 20 minutes left until 10 o'clock. If they haven't arrived by then, I won't wait.
Chuangsin.
What are the results? What's the lactic acid level?
It just came back at 3.4.
Luckily, it hasn't reached 4.0.
Care and professionalism.
Dr. Lin? About that patient. Why did the chief leave? Didn't the ER say that surgery was needed? My wife is in so much pain. Her clothes are soaked with sweat. When exactly can we sign the papers?
I understand how you feel. Please don't worry, we are waiting for the data for a key indicator. If it's the condition that we suspect we can't operate, surgery won't just fail to solve the ischemia, but might also be life-threatening.
If you don't operate, isn't her life still at risk? She's dying from the pain. Are you guys unsure about being able to treat her? If it's really not working out, can we transfer to another hospital?
We're monitoring her closely. If her indicators become abnormal, we can perform surgery at any time. The operating room door is staying open. Please give us another 20 minutes. If you transfer her now and an intestinal perforation occurs, it will lead to septic shock. I'm Lin Shu from General Surgery. Where is your consulting doctor?
They should be on their way.
The person from rheumatology hasn't arrived yet.
They're on the way.
The dressing change for bed 27. I've finished it. You don't need to look after other beds today. Which bed is Joe Chomei in?
Over here.
Active SLE. It's basically confirmed lupus-related mesenteric vasculitis, small vessels, diffuse immune inflammation. Even if you cut out this section of the intestine, it's useless. As long as the immune cells are still attacking the blood vessels, you remove this part and connect a new segment, it will still suffer from ischemia. I suggest immediate methylprednisolone pulse therapy, 1 gram, for 3 consecutive days. As for the kidney damage, we'll handle it.
Postpone surgery and start steroids. Don't clear the OR yet. Tell anesthesia to keep someone on standby. Keep monitoring the lactate levels. If the patient has any life-threatening conditions, wheel them into surgery immediately. This is non-negotiable. Systemic lupus erythematosus needs treatment, but only by surviving will they have the chance to receive further treatment.
General surgery, this is Guran, this is the OR, right?
Dr. Gu, that emergency exploration, are we doing it or not? Or 9 has been reserved for you all morning. The surgeons for the next operations in orthopedics are complaining.
Keep it open. The anesthesiologist shouldn't leave either Director Han's orders. Watch the IV drip. If by 2 p.m. the patient's abdominal symptoms still haven't improved, then they must go to the OR, no other choice. If the vitals don't improve, intestinal necrosis inside the body is also fatal. Choose the lesser of 2 evils. Saving the life is what matters most.
Understood. Bowel sounds have returned.
Dr. Lin, I feel like my stomach feels a bit more relaxed. It's not as tight as before.
You're out of danger for now.
Thank you.
Rebound tenderness is gone. Bowel sounds are at 4 times per minute.
Are the lactate results out?
It's down to 2.8.
Is this the OR Guran from General Surgery, the one in room 9? Cancel the backup table. Let orthopedics take over.
I heard the patient is out of danger.
Out of danger for now.
Since the emergency yesterday, how long has it been since you closed your eyes?
32 hours.
Before the next round at 3, I would go lie down in the duty room for a bit.
I can still hang in there.
This is a doctor's order. No sleep for 32 hours. Right now, your judgment is at 80% at best. How can you treat patients like this? Go sleep. I'll keep an eye on things for you. I'll wake you up when it's time.
What are you standing there for? Hurry and wheel the patient into the OR.
Oh, okay. The surgery was a success. The patient can be discharged so soon.
I'm being discharged. My little shoe has finally grown into a big tree. You can now provide shelter for others. But son, Mom hopes you'll also take care of your health.
Mom.
The results are in. It's systemic lupus erythematosus.
Dr. Lin, this disease, can it be cured?
It can't be fully cured, but it can definitely be managed. As long as it's caught early. Take steroids regularly and immunosuppressants. Go for regular checkups. He won't experience today's situation again. You can live your lives just as you normally would.
As long as we can keep living our lives.
Mom?
I caught him.
It's so itchy. I went to the clinic the other day. The doctor said the wound had healed, that the itching was normal, and told me to apply some scar cream.
If the problem is internal, topical ointments won't help. It's not scar hyperplasia. Bear with me for a moment. It might hurt a little.
Dr. Lin, I finally feel better. This is the thing that's been bothering me for over a week.
This is a leftover suture end from when the stitches were removed. It's a suture rejection. We'll disinfect it and then you can go.
This is the 3rd time this year. I've been in clinical practice for 15 years. Gallbladders, appendixes, hernias, I've performed thousands of these surgeries. No matter how perfectly the surgery is done, what's the point to be promoted to associate chief? You must have 2 core journal papers without rare cases or cutting-edge data. Even if I polish the writing to perfection, what's the point? What is this?
Takayasu arteritis, leading to mesenteric vasculitis in general surgery. This is an extremely rare immune-related acute abdomen. This case is rarity, and the clinical turnaround, perfectly meet. A high-quality case report standard. In the attending physician column, I wrote your name.
Why did you put my name? You could have kept it to publish as the first author. This was originally...
Your project.
You deserve the credit.
Joshua May's case files, from the emergency admission for misdiagnosed acute abdomen to the large vessel involvement, and then the immune markers, sudden complement drop intervention to conservative treatment, the entire treatment timeline. CTA screenshots have organized everything, in chronological order and archived it. When Director Han was on rounds, you bore the pressure and called for that emergency consultation. You didn't give up then. Besides, right now I'm just a resident trainee. Keeping this case is useless to me.
Thanks, Lin Shu.
I can't take this anymore. Life is just impossible.
Respiratory is sending more cough patients.
Forget the coughing. It's the residency assessment. It's the Monday after next general theory plus practical skills. Look at previous years. The pass rate is under 65%. If you fail, they'll dock over half a month's bonus and delay your rotation.
Even for you local residents, it's so competitive I thought only us visiting fellows were under this much pressure.
So. I heard from my instructor that for this surgical written exam, the questions are about the biliary system's anatomical variations. This kind of thing, aside from the chief surgeons at the operating table who could possibly memorize from a book those twisted and winding bile ducts. I originally wanted to go to orthopedics to crack some bones, but now I have to memorize plumbing blueprints from a book. It's driving me crazy. I'm done eating.
Don't worry, honey. I'll be discharged soon. A few truckloads of frozen shrimp just arrived. The stall can't run without me. Don't worry about me. Just put the younger one to bed after feeding. All right. The goods arrive tomorrow morning. I'll head home right after shipping them. Doctor, I'm ready to be discharged. The other doctor said I'm all better.
I remember you hospitalized for cholecystitis, and you had a cholecystectomy, right? Let me give you an exam before you leave.
I feel like I'm already recovered. I feel great right now. Besides, Dr. Ding already examined me and said everything looks good. It's fine. Really, I know you mean well, but I know my own body.
You just hiccuped. That's a symptom of diaphragmatic irritation.
Dr. Lin, you're crossing the line I've already performed. The examination temperature, blood work, drainage volume. Which one of these is not normal? And the lead surgeon was Guran. That was Guran's surgery. On what grounds do you say he can't be discharged?
I told you, the patient has abnormal diaphragmatic irritation symptoms, and he just touched his right shoulder. There might be discomfort in the right shoulder. He needs further testing.
Just because of a hiccup and a shoulder that's sore from sleeping, you're using that as a diagnosis. Does that paranoid routine from the ER even work in surgery? He doesn't even have signs of peritoneal irritation.
It's not on the abdominal wall because the leaking fluid is minimal, or it's wrapped by the omentum under the liver. It's not irritating the parietal peritoneum, but it has already irritated the phrenic nerve branches. If he walks out of the hospital doors now and gets into his refrigerated truck, in 12 hours at most, the seal will fail and fluid will flood into his abdominal cavity. He won't even have enough time to get back to the hospital for emergency rescue.
How can you guarantee your guess is right?
Because so far up until now, I've never been wrong.
Who says my patient has an abdominal leak?
Dr. Gu, the patient's phrenic nerve shows signs of irritation. I suspect there's a hidden leak in the surgical area. It could be the stump, or it could be some kind of anatomical variation. I need to pull up the laparoscopic footage of this surgery to confirm.
Fine. You want to see it? I'll take you there. I'll prove it to you once and for all.
Enough. I don't care about your so-called proof. I have to get back to deliver the shrimp. These 2 tons of shrimp, if they don't ship out tonight, are you going to pay for my losses? Don't rush me. I'm coming right now.
Feng Jungo, you can't leave right now. His abdomen is rock hard, board-like rigidity, diffuse peritonitis across the abdomen. Guran, notify Dr. Wei immediately. Start emergency resuscitation.
Dingnan, hold the elevator.
He actually got the diagnosis right. How on earth did he do it? His physical exam skills are incredibly good. Is he even human?
Dr. Ding, the elevator. Notify the OR Prep or 9 for emergency. Anesthesia, prepare for intubation. As for Dr. Wei, I'll notify him. Proceed directly to open surgery. Lin Shu, quickly get the patient onto the gurney. Get him to OR 9 immediately.
It didn't just shatter, but simply disappeared. It means we couldn't stop the hidden danger from erupting.
Dr. Lin, you've already done an amazing job. The patient wouldn't cooperate. You really can't be blamed for this.
What's going on with the patient?
It must be an aberrant duct in the gallbladder bed. A small bile duct has ruptured, causing a bile leak.
The patient's body is full of bile and blood. We can't find the gallbladder leak point at all.
We must find the wound immediately. The sooner we find it, the higher the patient's chance of survival.
Found it right here.
Impressive. Quick, Guran, you do the suturing.
A 1 in 100,000 chance. Though it's very low when it happens to an individual, it's 100% if you hadn't stopped him. He would already be in the morgue truck by now.
It's just habitual caution.
Habitual caution. I should learn that from you.
Left accessory hepatic duct, right accessory hepatic duct. This is already confusing enough. Why is there also aberrant bile ducts paraganglia? This kind of 1 in hundreds of thousands rare vascular variation. An attending physician might go their whole life without ever seeing one. Is the exam preparer out of their mind to test this stuff? If anyone can answer this, I'll call them Dad. The duct of Lushka, also known as aberrant gallbladder bed bile duct. What in the gallbladder bed area? There is an accessory bile duct not connected to the main duct. It grows directly from the right hepatic lobe and enters the accessory bile duct at the gallbladder base. After a routine gallbladder removal, if you're not careful, this extremely thin duct will break and it will continue to leak bile into the abdominal cavity,
Leading to biliary peritonitis. One of the most obvious early clinical signs is the bile irritating the diaphragm.
which causes.
Hiccups and right shoulder pain.
How did you even memorize such obscure and niche knowledge points like this? You're in the ER every day seeing fever and diarrhea and in general surgery every day stitching wounds. Where do you find the time to study this?
I didn't memorize it. It's just that last night I performed an abdominal surgery and removed one.
I knew it. Why would they suddenly test this? It turns out it's because of you.
Next is the final test, SP level critical care consultation, which means actors play the patients. We need to diagnose the condition and then perform standard medical procedures. I heard from the previous group who just finished, the surgical guys said the actors hired this time are supposedly from the Drama Academy. They're very professional. They act so realistically.
That's impressive.
So once you're in there, don't let your mind wander. With that Sherlock Holmes mindset of yours, I know you're a genius, but this time they're testing our basic skills. Just follow the standard procedures. Don't deviate from the main task, otherwise the examiner will mark you down for missing the key points and deduct your points.
I understand.
Sir, have you ever had heart disease before?
Where are your family members?
Did you
eat anything contaminated today?
Poor mental composure, swayed by the patient's emotions, failed to detect signs of shock, failed to prioritize the assessment of vital signs.
general surgery?
Candidate number 015, Linshu, please enter examination room 6.
Good luck. Hello, I am Dr. Linshu, the doctor on duty. Where do you feel the most discomfort right now?
Instructor Lee's acting is getting better and better. Save him. His aortic dissection has ruptured. They don't actually think this is still part of the exam. Do they stop the exam?
The patient's blood pressure is crashing.
Highly suspected type A aortic dissection rupture. Get a gurney in here right now.
Bring in a real crash cart.
Gosh, this candidate, has he gone crazy? This is a national level residency training assessment. He just yelled directly at the chief examiner director Shen. Is this student too caught up in the role? Should we ring the bell and disqualify him for a violation?
Seal off the exam room, countdown bell ringing.
Notify the OR to prepare.
Emergency rescue. Go get the elevator. Hurry.
What happened?
Aortic dissection. Signs of imminent rupture. Asymmetric pulses in both arms. Left pulse is extremely weak. Right pulse is extremely strong. Tearing, radiating pain. This pain definitely isn't something that can be faked. No one can fake it to this extent. Even an Oscar winner couldn't do it. Lower the pressure.
Must lower the blood pressure immediately.
Director Chen's assessment today.
In the script.
Doesn't include real emergency supplies. Only saline is real.
Go to the ER downstairs for medication. No. There's no time if we don't lower his blood pressure. He won't even last until he reaches the OR.
It's tearing. I feel like my back is splitting open. Director Shen Li.
Has something in his pocket. Captopril.
No, in his current state, he has trouble swallowing.
He'll aspirate it into his trachea.
So aggressive.
What a wild way to perform first aid.
That's a real eye-opener.
Leave it to us.
Suspected type A, aortic dissection, systolic blood pressure peaked at 220. Had the patient take captopril powder sublingually. The BP is down to 170 now. Did you do a CTA? No time for that. Go straight to the intervention room. Do it on the table. Confirm with angiography. The patient's BP is still surging up. I'll leave him to you. We've got it.
Rinse your mouth thoroughly how bad this medicine tastes. I know. It's quite numbing. I feel like my tongue has lost all sensation.
At that time, how did you tell?
On his forehead there was real sweat, not just cold sweat. Even the veins on the back of his neck were spasming abnormally. This isn't something acting can control. An autonomic nervous response. Plus his left hand, instinctively trying to grab. Something I took the chance to feel. His radial pulses on both sides. The pulse pressure difference was too large.
The residency exams are national and provincial standardized tests. Even though you saved the patient, I still can't give you a score, but rules are meant to prevent quacks. They ensure that if something goes wrong, at least procedurally, no one can find fault. This assessment is void. I'll apply to the higher-ups to give you a separate retake. You won't have to delay your training or lose your performance bonus. I'll write the report. Go back these next few days, review well, and wait for the notice.
Thank you, Director Shen.
And also,
you crushed the pills very finely.
that was a pretty wild approach. Even in the ER, someone with years of experience wouldn't dare to do that. Director Shen's decision is correct. Hospital procedures and rules are very important. It's not just to protect the patient.
But also to protect you, I know a retake is good enough for me. You're still smiling.
This afternoon, the Medical Affairs and Education departments held a brief meeting during the OSCE exam. You crushed the patient's oral antihypertensive medicine and forced it into his mouth. You even flipped the table at the critical care station and tossed it aside, then pushed the crash cart straight downstairs. Now this whole thing is known throughout the hospital. All my friends are asking me about you, asking if general surgery is hiding a monster.
Type A aortic dissection. In the ascending aorta. Just 1 centimeter away from tearing into the innominate artery. When that patient was put on the bypass machine, at that moment his BP spiked to 200 again. If you hadn't forced that mouthful of captopril powder into him and suppressed his BP, for those 10 minutes after leaving the exam room, he never would have made it to the operating table.
That's good to hear.
But credit is credit and mistakes are mistakes. Director Shen is the head examiner. For your assessment, the entire surveillance footage will be archived province-wide. A make-up exam in 1 month, specially arranged for you, a single exam, with Director Shen still acting as the head examiner.
Archived province-wide.
Is that all you're focused on? However, this surveillance footage will likely be shared with other hospitals. Saving someone in the exam room is a great merit. The higher-ups all know about it. You'll have no problem staying on as permanent staff. Our provincial hospital is the best in the province. Many come for residency every year, but those who can stay are few and far between. But we must follow the rules. This is for the sake of appearances, for everyone else to see, so that every step you take is on solid ground.
I understand. Thank you, Dr. Wei.
By the way, regarding that medical record from a few days ago, I wrote a paper for a core journal and added you as the second author, for a resident to be the second author in a core journal. Even if you take the written exam with your eyes closed, your overall score will still exceed the excellence threshold. One good turn deserves another. I acknowledge the work you've done for me.
Thank you, Dr. Wei.
Don't be so quick to thank me. There's one more thing. Director Shen didn't just approve your makeup exam. He also consulted with Director Han and the heads of the education department.
To discuss your upcoming rotation placement. According to the original plan, my next stop should be respiratory medicine, right?
You don't need to go to respiratory medicine,
A place like general surgery.
where you just routinely remove gallbladders and take out appendices, can't contain those x-ray eyes of yours.
Let alone respiratory medicine Director Shen, from emergency, thinks that's not enough to push your limits. Dr. Wei, where am I going next?
Critical care medicine, also known as the ICU.
That place, needless to say, the patients you've seen before could at least tell you.
Where it hurts.
Or what's bothering them.
But in the ICU,
From head to toe.
they're covered in 7 or 8 tubes.
Patients can't speak, nor will they have any reaction.
When you examine them.
That is a place where you snatch lives back from the Grim Reaper. Going there is very challenging.
Are you scared?
Not at all.
You're going to the ICU.
Yeah.
The day after tomorrow.
The ICU doesn't have the authority to perform surgeries independently, but they are there every day doing procedures for patients like deep vein punctures and inserting indwelling needles. The suturing skills you honed in general surgery don't let them deteriorate after just 2 weeks there.
Don't worry, I won't.
No matter how loud the ICU machines beep, remember, the one lying in the bed is still a human being.
Want to grab dinner together later?
I have a shift later. You go ahead.
Last night, while on duty at the hospital, I was even hearing people cough in my dreams. All that wheezing and that wet, phlegmy sound. The coughing made my pillow vibrate. Along with it, pulmonology is really no place for humans. It's like a giant 3D holographic orchestra. Seriously, though. What you did has now become a legend. Even my classmates working at other hospitals called to ask me about it. They asked if our hospital really produced a legendary talent who flipped the examiner's table just to save an actor during the exam. Even though you got a 0 among the residents, you've become a total legend.
Lin Shu, the paper's layout is finalized. It'll be published next month. I've already notified the education department about your status as second author. Let me treat you to dinner this weekend. No one else, just a few from our team, okay?
Thanks, Dr. Wei.
Take it easy in the new department. Don't cause too much of a stir.
Your mentor is so polite to you.
Dr. Wei is a nice person.
I heard you're soon starting your rotation in the ICU. Good luck.
Dr. Luo, I'm Lin Shu.
The ICU doesn't need detectives, nor does it need tailors. Here, there are only mechanics saving patients. Go change into your isolation gown. Bed 13 is being resuscitated.
13. There are too many fatal causes, even the system.
Can't accurately determine.
On her body, the most fatal lesion, which one it actually is.
Or to be more precise, every lesion here.
Could be fatal.
Her neck is so swollen, the ultrasound probe pushes out nothing but pus. The carotid pulse can't be felt at all. Your supervising director said, "You have a pair of hands with x-ray vision now. You have 1 minute to perform a blind internal jugular vein puncture. If you can't find it, she'll die right here." If you're not sure and afraid to do the puncture, then let me handle it.
I just think a matter this important should be left to a doctor who's certain.
48 seconds left.
Because I'm not sure either. It's a Hail Mary. The neck is too swollen. The fluid in the vessels has likely leaked into the subcutaneous tissue. The internal jugular vein is probably as shriveled as a dehydrated earthworm.
If you can't find the spot, then let me take over. I'll perform a venous cut down.
Shut up, quiet. Stop ventilation. Found it. Flashback dark red, it's a vein. AOS.
It's secured. From now on, whenever I'm on duty with the team, all blind punctures and difficult intubations are all yours. The tubes you didn't finish practicing in general surgery, you'll get plenty of here. I'd like to see how your intuition-based blind puncture technique holds up in the ICU with a failure rate of a few parts per thousand.
Understood. What's the story with this patient?
A week ago, a car accident caused a ruptured spleen. He had a splenectomy, but after the surgery, his body suddenly collapsed and he was moved to the ICU.
There must be a root cause. Just like dominoes, the first one to fall is what triggers the subsequent chain reaction.
I'll give you all the reports since the patient was admitted.
Thank you, Dr. Luo. Where is it? Right here. No, is this the cause? That's not it. This isn't the primary cause. Dr. Luo, I found it the cause for bed 13's condition.
All right, go ahead.
The trigger for her systemic symptoms isn't in the chest cavity or in the blood. It's a surgical issue inside her body. There's a leak.
A leak. Her spleen was removed in general surgery. The spleen is a solid organ. It's not the intestines or the stomach. There's no such thing as a leak there. Besides, her drainage tube hasn't shown a drop of intestinal contents or gastric juice, so tell me, where exactly is the leak?
It's not the stomach or the intestines. It's a pancreatic leak.
A pancreatic fistula.
The impact from the car accident didn't just crush the spleen. It also caused a hidden contusion right next to the splenic hilum. To the tail of the pancreas, I checked the general surgery records. The bedside ultrasound from 2 days ago, there was only a small amount of localized fluid in the abdominal cavity. There was no sign of a large-scale accumulation of pancreatic juice because her drainage tube was positioned right in the splenic fossa. As soon as the pancreatic juice leaked, it was immediately sucked away by the tube.
You mean?
Exactly. As long as that hole in the tail of the pancreas is still leaking fluid, no matter how high the dosage of norepinephrine you give her, you're just maintaining a corpse that's dissolving from the inside out.
I'm calling general surgery.
Hello, general surgery here. Who are you looking for? I need the person in charge, the second-line doctor on duty. If I remember correctly this morning, it's Director Han's team. I'm looking for Director Han General Surgery Desk. Who is this?
Luo Fing from Critical Care, the patient you sent a week ago. Bed 13 with the splenic rupture. I suspect that she doesn't have postoperative absorption fever, leading to a common infection. It's a blunt impact occult pancreatic tail contusion that caused a delayed pancreatic leak. On the 4th day, you gave her high-dose intravenous fluid replacement, which pushed her directly into total collapse, edema, and microcirculatory failure. Dr. Luo medical diagnosis requires evidence, not imagination. The bedside ultrasound from 3 days ago showed no large-scale abdominal fluid. If it were a pancreatic leak, signs of peritoneal irritation would have surfaced long ago. Besides, her drainage tube. Every day, dozens of milliliters are drawn out without the characteristic clear and viscous pancreatic fluid. I have 3 sets of progress notes here to support this. The drainage tube's position is exactly in the splenic fossa. So it acts like a pump sucking out some of the small amount of leaking pancreatic fluid, and the cloudy drainage fluid isn't pus. It's because the surrounding fat was digested by pancreatic fluid, creating emulsified saponification spots.
Your deduction is brilliant, but what proof do you have that the cloudy substance is pancreatic fluid? Where's the lab report? Since when does the ICU rely on the naked eye to diagnose patients? Director Han, this is Lin Shu. If her drainage fluid's amino acid level is higher than normal blood, by over 500 times, can that be used as an indication for laparotomy? Are you in the ICU? I just transferred today.
5 minutes, I'll be right down.
What about the amylase?
I'll draw it now. Send it for bedside biochemistry stat. We're only missing the drainage fluid amylase test result.
Notify anesthesiology and the OR.
Send down a full backup set of
laparotomy instrument kits and the electrosurgical unit.
Are we taking her upstairs to the OR? Her circulation can't hold out through the elevator and hallways. She'll rupture if we move her.
We're not going to the OR. Bring the ICU surgical light over here, right here, bedside laparotomy.
We can't maintain a sterile environment here. There's a risk of infection.
You have to be alive to worry about infection. The omentum is completely necrotic.
Blood pressure dropped to 70, tissue traction.
Vagal reflex, norepinephrine. Double the infusion rate, I found it. This is bad. Massive hemorrhage, VFib, cardiac arrest. Prepare the defibrillator. Charge the defibrillator, 200 joules. Everyone stand back, Lin Shu, hands off. Epinephrine. Prepare the second dose. Lin Shu, clear again in 10 seconds.
Confirmed.
She's back.
Lead surgeon. It's up to you. She's on norepinephrine and dopamine stimulation. This heart can only last 20 more minutes. If you don't close the abdomen within 20 minutes, she still won't make it.
Lin Shu, can you handle this?
I can.
You be the first assistant, Guran. You're the second assistant. No, her internal organs are too fragile now. Like a piece of soaked tofu. This suture is like steel wire to her, a little too much force, and her pancreas will be crushed.
I have a plan. We can use the thinnest IV cannula. Take the soft tube sleeve off the tip, cut it into 2mm segments, thread them onto the Prolene suture to use as artificial pledgets for tension-reducing sutures.
That works.
23,300.
The surgery was a success. When you were on her sternum doing those compressions, you used too much force. At least 3 ribs are broken. This shows she has severe osteoporosis. She might also face a flail chest later. But if you hadn't jumped on the bed to perform CPR in the 10 seconds we spent finding the leak, her brain would have suffered massive necrosis due to lack of oxygen. She would have been a vegetable.
That tube trick was clever. Well done. I'm done writing.
It's finished. I've updated the primary diagnosis and added the bedside laparotomy rescue record.
You identified the cause accurately, and your technique was bold. Enough to break her ribs, but without notifying the head nurse. You used a syringe to extract fluid from the sterile drainage tube. That violates the 5th red line of retrograde infection prevention. I've sorted the paperwork for you. All right, go get some food and come back soon.
Got it, Dr. Luo. Over here. Boss, 1 beef ramen with extra meat.
For your first day in the ICU, you sure made quite an entrance.
The group chat is buzzing. You just moved from general surgery to the ICU and immediately humiliated your former department.
I saw her blood gas analysis in the ICU system using amylase to crack the case was a brilliant piece of reverse deduction.
Just a lucky guess.
How can this be? During morning rounds?
He was still chatting with me.
Saying he wanted an orange. Okay, I'm coming back right now. I need to head back first. My friend is in the hospital because he's unwell. He just went to the bathroom. And his blood oxygen suddenly dropped to 50. The instructor said he's shivering and turning blue. They're rushing him to the ICU now. They told me to wait right outside the ICU.
I'll go with you.
What happened? Give me the patient's information. Joe Rui, bed 21, my high school classmate. He's 23 and just graduated this year, working at a design firm. It was just a common fever, cough, and a fracture. He was admitted to the respiratory department. I've seen his chest x-ray. Initially, the lung markings were just a bit thick. They said it was mycoplasma or a common viral infection. He was still complaining to me this morning, saying he just became a full-time employee. This illness couldn't have come at a worse time. He's afraid his boss will let him go if he's out too long. He even asked me if he could bring his laptop tomorrow to work on some CAD drawings in his hospital bed. He's always been such a good person. Someone as kind as him. How could he end up in the ICU so suddenly?
Move aside.
Linshu. You're so capable. Please help me save him. He was just chatting with me this morning.
I'll do my best.
His lungs are failing. Air can't get in at all. It's a classic case of acute respiratory distress syndrome. The rate of deterioration is the fastest I've ever seen.
Like cement, his lungs are completely blocked, just like two solid iron bricks filled with lead. Air can't get in, and he can't breathe on his own.
He's going to suffocate to death, intubate him, and give him sedatives and muscle relaxants. His spontaneous breathing right now, aside from consuming oxygen, is completely useless. Suppress his respiratory drive. Use the ventilator's high pressure to force his lungs open. He is on the ventilator now. Pure oxygen ventilation. PEEP adjusted to the maximum limit, 15 centimeters of water. It is not working. His oxygen levels won't go up 75%.
This is bad systolic blood pressure dropped to 60 jugular venous distension.
Tension pneumothorax. Stop the ventilator. We can't keep using it. If we continue, his lungs will burst. Lower the pressure. Maintain low-speed ventilation. Stop forcing air in. If you keep blowing, his other lung will explode too. His lungs have quit right now. No matter how much oxygen we pump in, it is like blowing air into a rock. Go call the medical affairs office and cardiothoracic surgery. Start ECMO.
Start ECMO.
If we don't, he won't last past midnight. Starting the ECMO machine. That is 50,000 and 15,000 every day. After that doesn't even include the cost of antibiotics and nutrients. Have someone notify the family outside. Tell them to bring the money and the DNR consent form and come to the consultation room. ECMO. This is to date the most expensive and most extreme life support tool in medical history. Every day is like using gold to fight for his life against the Grim Reaper. He is on the machine. He is living on extracorporeal circulation now, but as for when he will wake up, or if his lungs will ever recover, it is medically impossible to tell. Maybe tomorrow, maybe in a month. Or maybe he will never wake up and eventually die from other secondary infections. This means starting today. For this machine, you will need to prepare 15,000 yuan a day with no upper limit. If we stop the machine midway, he will die immediately. You need to think this through. There is 60,000 in this card. Tonight we will call our relatives to borrow money.
Doctor, my son just sent a WeChat message yesterday saying he got a year-end bonus and wanted to buy me a smartphone.
We can't pull the tube. Not even for a day. I brought him home from the hospital when he was born. And I'm going to bring him home this time too.
Contact the Medical Affairs Department. Apply for the Poverty Fund.
Use the Emergency Rescue Fund Advance Payment Process.
Every day we can stall counts. I thought I was used to life and death, but I realize I'm still not.
Lin Chu.
While in the ER, even a 1 in 100,000 case of Takayasu arteritis, you were able to diagnose. Can you tell if his lungs can still be saved?
I can see the cause, But as for the cure...
I know. You.
Thank you. It's not working. All the top experts conclude in their papers that the only way is to maintain extracorporeal ventilation, use pulse steroid therapy for infection, along with assisted ventilation, and wait for the lung function to recover on its own. But at $15,000 a day, his family simply can't afford it.
9 o'clock training center on the 7th floor. Go for your retake.
I'm not finished yet.
Hurry up and get your professional certification retake finished. Stop acting like a savior all the time, sitting here staring at the screen. If your head is filled with cement, then in here, you're just a piece of junk wasting electricity. Just go already, 9 o'clock. Training center on the 7th floor, go for your retake.
Oh, it's killing me.
Lie flat and bend your knees.
This doctor is so mean. Migratory right, lower quadrant pain, atypical signs of peritoneal irritation. Order an urgent CBC and an abdominal ultrasound. Suspected acute simple appendicitis. Administer IV cephalosporins in the ER.
Director Shen.
Is this student. In a foul mood today, the diagnosis is correct, but his attitude is too cold. Bedside manner and communication. Physical exam protocols and etiquette, with points deducted from these categories.
I doubt he'll even reach the passing grade. His mind is completely on that patient on ECMO. This exam is just a formality to him. This is what a real compassionate doctor looks like.
So, does he pass? What do you think?
You're giving him this score.
He didn't finish the process. Let's just say he barely passed. He got a few key points right. A passing grade is about right. A low score is actually better. Just let this.
Barely passing score. Stay on his record as a cover to keep him from being poached by other major hospitals.
In another 6 months, it'll be the graduation poaching season. Those hospitals in the capital, those legendary national-level ones, top-tier critical care centers, and the ones in Shanghai, those elite Class A hospitals, every year, they're down here, quietly casting their nets, specifically scouting for top talent. In our hospital, we finally found a rare gem. We have to keep him hidden. I'll have him join my ER when the time comes.
Then go talk to Wei yourself. General Surgery is keeping a close eye on him too.
Sis, it hurts. My leg hurts so much.
You called me just now to change his dressing.
Yeah. Thanks for the help. Gu Xiao, shut up and be quiet. If you keep shouting, I'll use an electrosurgical knife to cut off your leg and then have someone carry you to Director Gu's office. The asphalt and engine oil have completely entered his muscle pores and fully solidified. We can only use a syringe for forceful irrigation.
Sis, give me some anesthesia. It hurts so much.
If you knew it'd hurt, why go street racing? You'd deserve it if you ended up crippled one day.
Irrigation. I've got it.
Thanks.
No problem. I'm leaving now. Dr. Luo, I've thought of a way to treat Joe Rui.
What way?
High-volume aggressive whole lung lavage, combined with high-concentration PS solution for microblast dilution, since the ventilator air can't clear his lungs. Then I'll flush them with water. Into his lungs, I'll forcefully infuse several thousand milliliters of solution. Then use manual water pressure and chemical properties inside the closed thoracic cavity to create physical oscillation and stripping. Finally, use a high-power suction device to draw out all the impurities along with the solution.
You've worked too many night shifts. You're hallucinating.
This is the method I came up with after going home.
Severe ARDS isn't coal dust disease. His alveolar walls are as thin as a piece of wet rice paper. If you pour this much water in, the water pressure will directly collapse his alveolar walls instantly. All that water will flood back into his bloodstream. Before the water can be drained, he will suffocate to death with such high water pressure, his heart simply won't be able to take it.
He's different. He's on ECMO right now. An extracorporeal circulation machine is basically an external invincible second heart. A human heart might fail, but a mechanical heart can handle it. The moment water fills the alveoli and pushes back against the blood, I can manually push the ECMO's speed to its absolute limit. Use this machine to intercept the pressure on his heart.
You're a madman.
This method of yours only exists in theoretical models. There are no clinical guidelines to support it. The price is gambling with his life. His father, the one in the old military coat, is selling everything he owns, using money borrowed from the whole village to keep his son alive. For a family like this, the sunk cost has already reached its limit. If we follow standard treatment, even if he doesn't make it, it's just fate, they would accept that. But if we use your method... and he dies, you will become the target of the family's anger. They might pin all the responsibility on you. Your career, your future, your prospects will all be ruined by this gamble. You'll never be a doctor again.
I just went to pay the bill. Today's fees are paid.
Sir, please come with me. Sir, that $15,000 machine. Can't pump the blood anymore. We don't have to wait until tomorrow. He'll be gone by this afternoon. But Dr. Lin inside. Late last night, he figured out a way. A way that might just save your son's life, but the risk is enormous. If it fails, he might die on the spot, because this method isn't written in any medical guidelines in the world. So the director is afraid to let your son go on the operating table. He's afraid that you'll end up losing both your son and your money, and then sue him for premeditated homicide. Sir, I'm just a low-level doctor who treats colds. I shouldn't be telling you this. But Joe Rui is my friend.
Sir, do you dare to take the gamble?
Please, doctor, I'm willing to take the risk. Doctor, I beg you, if it fails, I'll accept it. This is Ruir's fate.
But if I don't dare to take this chance, I won't be able to live with myself for the rest of my life.
Notify the pharmacy. Get 50 vials of high-concentration pulmonary surfactant immediately. Put them all in the incubator. Heat them to 37 degrees. I'm betting my entire career today to take this gamble with you. At worst, both of us will lose these white coats and get kicked out together.
I will do my best. Not to let everyone down.
The machine is maintaining circulation. It's holding up.
It's coming out. The impurities in the lungs are being suctioned out.
Airway pressure is dropping. Air resistance is decreasing. This clogged cement lung can finally breathe.
Stopping the medication. Adjust the cardiotonics. Maintain the baseline heart rate.
The procedure from the last half hour. Don't record it in the handover notes as large volume lung lavage, just right routine bedside bronchoscopic deep sputum suctioning.
Understood.
Although the family took the blame with their blood-stained thumbprints, until this kid can open his eyes on his own. Both of us are still standing on the edge of a cliff.
Oxygen saturation is back above 80. He didn't die on the table. He's alive.
Better than before.
Thanks.
Dr. Luo. The people from the equipment department. The on-site engineer just left. The ECMO machine used on bed 21 yesterday due to overclocking beyond its limits. The centrifugal head's main bearing is severely worn. The manufacturer's assessment is that it was an operational violation and it's not covered by warranty. The repair bill is $108,000 also. Yesterday afternoon, you bypassed the hospital's special drug approval committee and forced access to the backup pharmacy to obtain 50 units of non-catalog pulmonary surfactant. Currently, it cannot be covered by medical insurance, nor can it be taken from the ICU's contingency fund. That's a deficit of $45,000, totaling $153,000.
I see this matter. I will take full responsibility myself. I will submit the report to the director's office this afternoon. Whether it's a fine or suspension, I'll accept it. Dr. Luo,
Trainees don't have signing authority. This $150,000 debt has nothing to do with you trainees. Get back to work.
Director Shen, this is Lin Shu. Yesterday afternoon, while dealing with a case of severe white lung, complicated by fibrosis, the ICU, with the ECMO overclocked to its limit for compensation, performed an unauthorized high-volume, whole-lung artificial lavage. The patient has now regained stable vital signs. But this procedure resulted in $153,000 in unauthorized losses and costs. If reported normally, the attending on duty, Luo Feng, will face an internal audit, resulting in a warning at best, or suspension at worst. Calling me won't help.
This is an ICU matter. I went easy on you in the exam, not so you could be arrogant and break the system's rules.
No, you can make this useful, and it's a win-win. This rescue case is groundbreaking in terms of administrative penalty. It's a loss of $150,000. But if we reframe the report, it becomes a piece of cutting-edge research, a research achievement that can benefit the Science and Education Commission and the hospital. That's not enough on its own. I have all the lavage data and hemodynamic turning point charts if you lead the project and apply for a hospital-level grant. This $150,000 deficit in medical costs will become a preliminary research investment.
Fine. Then print out all the charts, underlying data, and original records and bring them to my office.
Overloading the machines. Unauthorized use of expensive medicine requisitions without any supervisor's signature.
Under such circumstances.
Changing the treatment plan. This bill, your performance bonus won't even cover it.
You take the fall for this. The whole department, everyone's year-end bonuses will all be cut because of you.
Not to mention if the operation fails, whether the family.
We'll tear this room apart.
I'll take all the responsibility myself.
You can't handle it.
Mr. He, I hope I'm not interrupting. Stop being so hard on your subordinates. The Vice Director of Education just now showed me yesterday's white lung case, the recovery case. To me, I found it quite interesting. This case happens to fill a gap in the hospital's research this year.
All right, these expenses will go through the hospital-level research fund pool as a full reimbursement. You write the report, and I'll sign it.
All right, you can go back now. This matter is over. This trainee you're protecting is quite a loyal one. Your rotation in the ICU is over. My heart rate this month has been more intense than the whole past year. You're excellent, but you must learn to protect yourself.
Thank you, Dr. Luo. I've learned a lot here, too.
Dean Chen, really? That is just an ordinary trainee.
You've got it wrong.
That reported severe ARDS case, total lung extracorporeal elution compensation model.
The underlying negative pressure circulation
And the derivation logic.
are definitely not things your provincial hospitals.
Those few associate professors who just follow the book could ever come up with Dean Chen. Let me explain. This data was jointly compiled by several departments in our hospital. This trainee was just an assistant.
Bullshit. Do you think we at Sheehy, the old-timers on the review board, are blind and your hospital that paper published the month before last in the Journal of Macrovascular Diseases? This trainee named Lin Shu was the second author. Don't tell me your provincial hospital has two geniuses with the same name, working in general surgery and ICU respectively.
Dean Chen. This trainee doesn't even have his medical license yet. Last week he was even penalized for a violation. Just barely passed. He's just average.
Enough. Stop your little games of hiding talent. You won't be able to keep this talent. A genius like this, only at Sheehy can he truly reach his full potential. In a while, there's a national medical conference in the capital. Bring him along.
As expected, gold
Will shine wherever it is.
Truly.